Thank you, everyone, for joining us today. My name is Leslie Milano, and I am the CEO of APIC Consulting Services. You also see Catherine Hitchcock here. She is our Vice President of Business Development, and we are so happy on behalf of APIC Consulting to present to you today too much work, too few IPs, building capacity without adding staff. Few words before we introduce Dr. Bubb. This is a very timely topic. We've been talking to a lot of folks. This is really resonating. It's a critical moment for IPC. We thank Dr. Bubb for being with us today. This response to this webinar has been very strong. There's a lot of energy around the topic. What we're seeing and hearing is that workload is increasing for everyone in IPC. And I've been at APIC for about 18 years, and so that's not surprising. It always seems to be increasing, but there's a few things that are different right now. So more work, more complexity, more responsibility, but resources are flat. They are not scaling to meet needs. And burnout is rising at an unsustainable pace. Teams are strained, there are capacity gaps, and we have a looming retirement for a significant number of IPC department leaders. We know that IPs need help right now. At APIC and APIC Consulting, we've been working on a number of ways to support you, and we'll go through that today, and we'll keep this conversation going. So who is APIC Consulting? APIC Consulting is the consulting arm of APIC with 350 CIC certified consultants. We are now also responsible for selling APIC's bulk training, education, and other resources. And Catherine is our team lead on the business development front. I like to say one of her superpowers is helping facilities who are unsure about what they need to really walk through the process and understand exactly what they need and what that plan is moving forward. So we're here to help you. We also have other IPC resources that are available to APIC members and non-members for free. So next, I'd like to introduce Dr. Bubb. We have worked together with Dr. Tania Bubb for a very long time. She is the Senior Director of Infection Prevention and Control at Memorial Sloan Kettering Cancer Center in New York City. She is a nationally recognized leader in infection prevention and control and has worked at major academic medical centers with responsibilities spanning the continuum of care. Here at APIC, we think of her as a transformational leader in the field. She has shaped professional practice at the local and national levels through her service on the board of directors for the Association for Professionals in Infection Control and Epidemiology. She has chaired the APIC Professional Development Committee, led the Health Inequities and Disparities Taskforce, championed initiatives that strengthen workforce competency and embed equity into infection prevention practice. And in 2024, she was the president of the APIC Board of Directors. She's an accomplished speaker, a published author, and she's going to share her thought leadership with us today that brings evidence, policy, and frontline practice. So without further ado, Dr. Bubb, take it away.
Thank you, Leslie, and thank you to APIC Consulting for having me speak today on what we know is a very poignant issue for us in the IPC world. Welcome to everyone, and thank you for joining today's webinar. I'm pleased to be here with you for the next 45 minutes or so to discuss how we can build capacity on our teams. Our agenda will start with a discussion of the current state of IPC and the healthcare world. We'll then move into evaluating our bench or assessing what we have as skill sets. We'll talk about some program considerations and, of course, technology and automation. And then we'll talk about some resources and support that are available to you. I will be discussing resources you can use from APIC that are free or low cost as a note. And I'll also be referencing some ways my team and I have strategized to increase capacity without increasing staff members to provide salient and real-world experiences to you. Next slide, please. At this point, we'll jump into a discussion about our current state. Today's topic reflects a reality that many IPs are facing in their day-to-day lives. And as a preface, although this presentation primarily focuses on acute care, the concepts can be easily applied to any healthcare setting. There are increasing regulatory requirements. Many of our facilities are expanding in size, complexity, and expanding in services that are provided. There are also increasing costs and restrictions in healthcare that impact how each of our departments get funded and get budgeted. Expectations are higher and our work is more visible. We are asked to do more, faster. We are in a redefined nation, and the changes that have ensued are likely to be permanent. Often, when we feel there is too much work, we inversely relate this to the need for more people to do this work. The reality for many of us is that it is quite difficult to get administrative approval to add more staff to our programs. The feedback typically boils down to there is no budget for the IPC department. What is the return on investment? Or make what you have work. That makes it critical to be intentional about how capacity is used in our programs. We may need to reframe and rethink how best we use what we already have. That is our people, our systems, and our tools. This session will be practical and realistic and focused on capacity building in our departments. But first, we're going to take a poll. So we'll go on to the next slide, and there are 3 questions in this poll. We'll take maybe a couple of minutes or so to help for you to answer these questions. The first question, we're going to ask you to select 3 answers, and the last 2, 1 selection. So you should be seeing the poll right now. Remember to answer all 3 questions, and the answers will start displaying once we have enough participants participating. So your 3 biggest constraints: what best describes your infection prevention staffing today, and how do you feel you understand the strengths and gaps in your current team? I'm not yet seeing results pop up. Evelyn, are we at some point going to see the results pop up?
Yes, people are answering right now, and then once we end the poll, the results will.
Then we'll see it. Yeah. Understood. So once Evelyn sees that enough people have answered, we will be seeing the results.
We'll give it about 30 more seconds here, and then I'll end the poll. Okay, 10 more seconds.
Okay, here we have it. So a mixture of answers. Interesting, but it looks like not enough IP staff. I think we all could have predicted that one as the biggest constraint. If you'll scroll down a bit, Evelyn, or maybe I can scroll down. Let's see. Yes, I can. Which best describes your prevention staffing today? We're understaffed, but managing. I think that's like a model or a song we can create for IPCs. We're understaffed, but managing. And then the third question, how do we feel we understand the strengths and gaps of our IPC program? Somewhat bears out to be the winner here. Okay, thank you all for taking the poll. So now that we know what the general consensus is about our constraints, This brings me to the first major lever we can control, which is understanding our bench. This is who we are, this is who we have, what they can do, and how they are currently used. This includes our staff experiences, the training that they have, and how work is distributed. I'll note, we are not in the business, and nor should you be, of criticizing staff. Rather, this is about understanding capacity realistically. Next slide. We'll now consider whether staffing aligns with the work we are doing. Staffing needs vary by care setting, patient population, and regulatory demands. Using tools like the APIC staffing calculator can help ground us and ground our conversations in structure and data. Almost 2 years ago now, my own organization proposed budget cuts to our IPC department. My team and I used the APIC staffing calculator to show our leaders how understaffed we were. While we didn't acquire more staff, we avoided budget cuts having the potential to impact our staffing significantly. You can think about using the APIC staffing calculator to support planning, not necessarily as an absolute rule. Although I will mention that I have had several conversations with several director level IPs staff who have shared their account of successful acquisition of new staff just from using the calculator and showing the results of that to their leaders. And really that happens because the calculator is grounded in tangible data. Next slide, please. Headcount alone does not always get you to the outcome you desire, though. Staffing numbers matter, but skills matter just as much. You want to evaluate educational backgrounds. Is it clinical, non-clinical? Is it analytic or public health? Is it administrative or operational or laboratory focused? Years of experience is also informative. This can give you a sense of exposure and potential capabilities. What are the prior roles held by varying staff members in your team? What transferable skill sets is available on the team? Training, professional development experiences, certifications, and micro-credentials are important to evaluate also, because different experiences bring different strengths, thereby providing different areas of opportunity. Let's discuss certification options and micro-credentials briefly. Civic certifications start at the novice level with the AIPC and progresses through proficient, CIC, to advance with the ALCIP. And there is also the long-term care certification available, the LTC-CIP, covering a wide span of IP expertise. APIC also has 2 active micro-credential courses, surveillance and quality and safety. And their construction micro-credential course is not yet available, but is coming soon. Next slide, please. To really understand strengths and gaps, performing competency assessments are a key strategy. Competency assessments provide a structured way of identifying strengths and revealing opportunities. You can evaluate where support is needed or where your own level of performance is benched. Developmental goals and training plans can be created from competency assessments. On this slide, we highlight APIC's Career Development and Advancement Guide. In my own program, I've used this guide to inform a developmental career ladder for my team. But you can also use this guide to help you navigate your own career. Once we understand competency, we can be much more targeted with training. Training should be personalized, realistic, and tied to actual work. You may want to align your goals to training opportunities, and you definitely want to consider that the training is appropriate to your or your employee's background. In my department, any training or educational content we recommend or require is aligned to the employee's actual job expectations. You want to make sure that that training is not out of sorts with what the employee is expected to do. Develop regular progress check-ins with your team, or if you are an individual contributor, with your manager. Regular check-ins matter more than just a one-time training. I would recommend regular check-ins over training. The good news is that building skills doesn't always require large budgets. Focus on high value and accessible resources, such as those listed on this slide. If the trainer requires a fee or others can benefit from lessons learned, the trainee can bring back pearls for the rest of the team. Share resources across the team to help expand capacity. Each week, my team has what we call Pager Series. This is a brief 15-minute presentation by someone on the team sharing a topic that could come up in our day-to-day work. You could implement a journal club or schedule monthly free webinar trainings that the entire team takes part in. Remember that skill building is capacity strategy, not an extra. Although it can feel like extra work, the payoffs are well worth it. Another structured way to support skills and consistency is certification. We talked a little bit about certification. We'll talk a little bit more about it on this slide. Certification is validation of our expertise, and it provides consistency across our team. Certification builds credibility and confidence, and it supports consistency at the individual and program level, as I said before. It also strengthens the program when making the case to leadership. Certification is most valuable when there is investment at the individual and the program level. It's best when it's valued by both. People matter, and the program they work in matter also. We'll move into discussions about program considerations next. Be sure to have policies, procedures, and practice standards updated and easily accessible. The goal is a central source of knowledge. There is a time cost to not having documents updated and accessible with version controls. If anyone has experienced this, you know exactly what I mean. Set up regular routines to review workflows for efficiency. Eliminate unnecessary steps. Do not get hung up on habits and routines if it is not serving you the best outcome for the program. Ensure task allocations among staff are not overly light and likewise overly taxing on any one person. APIC's Policy Pro is a policy library and management system that can eliminate some of this tedious work. There are also other policy management systems your facilities may already use that you can tap into if you're not already doing so. Another major capacity lever is how we bring people into the role of IP. Poor onboarding delays productivity and increases frustration and burnout. While good onboarding is one of the fastest ways to build capacity, APIC's onboarding checklist is a great way to provide a structured onboarding approach. Providing structured, role-specific onboarding accelerates readiness and builds capacity quicker than a haphazard, unthoughtful approach. Remember, the quality of your onboarding can help with retention. At MSK, where I work, we dedicate 6 to 8 weeks of protected onboarding for newly hired novice staff. We provide shadowing and reading time alike. We ensure new staff are paired up with a more experienced IP mentor and provide regular check-ins opportunities. My predictable rhetoric to new staff is that their success is our success, and it's a win-win for all of us when they have been fully prepared to take on their dedicated assignment. And that should be your goal as well. So even with good people and programs, we still need to reduce manual and overtaxing work. One way we can do this is through the strategic use of technology. Technology should reduce manual work. You can use it to support you by reducing repetitive and low-level tasks. Look for opportunities to shift IPs from data entry to analysis and action. Next slide. Surveillance is essential and it's necessary. We know this, and it is time-consuming. You may want to focus on non-mandatory surveillance on high-risk areas to increase capacity and free up time for prevention and initiative implementation, interpretation, and action, rather than paperwork. The facility you work for will largely dictate your access to technology. You can explore how the technology available to you can facilitate efficiencies in your work. Review workflows, reduce redundancies and repetitive tasks. If you are tracking something electronically, stop also doing it on paper. Where possible, use one systematic approach. Capacity also grows when IPs aren't doing this work alone. Infection prevention is shared work and not an IP-only responsibility. Infection prevention, as I say, is everyone's business. IPC liaisons and interdisciplinary partnerships expand reach. Grow your tentacles. Be sure to rely on interdisciplinary support and IPC liaisons whenever that's possible. Shared accountability will expand reach without expanding staff. We'll now focus on some resources and support that we have gathered for you. Here are frequently used resource organizations for IPC. I know you all use these, and yes, CDC is still one of them. But besides what's on this slide, there are also your local health departments and hospital associations. Tap into those, your chapters. Often some of our chapters often have websites that they host information on, or even educational meetings. You may also want to refer to specialty-specific guidance, such as ARRN, FGI, AGIC, ICHE, ASHRAE. You probably can name a whole host more than what I can list here. Create a list of frequently used resources for easy reference and access. That's something that we have also done in our department, where we have a comprehensive list of all of the resources for all of the subspecialties that we are responsible for oversighting. And it makes it so easy to go to that list and figure out what we need to look at and where it is, rather than an anecdotal approach, if you will. And yes, this work took some time to do in the beginning, but now the benefits of having done that work have paid off, because now we're saving time. Sometimes internal strategies aren't enough, and that's when external resources can help. Capacity gaps don't always require permanent hires. Sometimes external resources can be used strategically and temporarily. That's where an organization like APIC Consulting can help. APIC Consulting is a consulting arm of APIC, as you've heard, that assists with supporting members with short or interim term needs. I'll now pass it off to Leslie, whom you met earlier, CEO of APIC Consulting, to discuss a bit more about their services.
Thanks so much, Tania. I was here many, many years ago when APIC Consulting was started. And the reason it was started was because there were so many requests from APIC members for different types of assistance. And because of APIC's nonprofit status, and the fact that it's a membership organization, it was not able to help in the kind of ways that it wanted to. And so it developed APIC Consulting in order to assist facilities. And we have assisted thousands and thousands of facilities since our inception. And so here's just a few areas where we are getting a lot of requests. So we wanted to share that with you to see, what other people are asking for these days, and that might help to spur some thoughts on your part. Because when there's more work and there's fewer people, something needs to give. And people are asking, for the most part, for a few areas of help. So one is assessments. We do assessments, program assessments, risk assessments, accreditation, preparation. We also do competency assessments and onboarding and mentoring plans for new IPs. If you don't have that kind of as Tania was just mentioning, if you don't have that kind of a program already up and running and working really well in your facility, that might be something that you need a little assistance with. Efficiency workflow assessments, trying to move away from the manual labor, as she was saying as well. We have interim staff, so either remote or on-site staff for any vacant positions to facilitate quality projects, to do some of the work that's not getting done, to assist with remote surveillance, to train staff, or just to, while you're, looking for another alternative there for hiring, and I know hiring is quite challenging right now, an interim staff person might be helpful to you. We also have fractional support, which is a little bit more sort of assists folks on an annual basis whenever you need it. And so you might just need 5 hours one week, no hours another week, 20 hours another week, whatever that sort of looks like. We can have someone who would learn about your facility and really be a valuable member, but just when you need it. So that's another opportunity there. And data analysis as well. We were talking a bit about with some folks recently about EPIC data analysis functions, getting the most from that system. And so while there are a lot of functionality, there's a lot of functionality if you use that system. We have some folks who are very, very well versed and can assist with creating the types of reporting and the analysis that you need. So that's very much in demand right now. And again, just overall trying to help folks reduce their manual labor in IPC departments. And what we're working on over here is ways to figure out how to insert AI in a palatable way for the organization in the facility, that would assist IPs and make them more efficient and maybe take out some of that burnout that they're experiencing right now. I'm going to send this over to Catherine Hitchcock, our Vice President of Business Development, to talk a little bit more.
Hello, everyone. Next slide, please. All right, so this is a little bit about what you should look for when you're looking for your consulting firm. Obviously, the skills, experience, and certain types of expertise are very important. If you are about to start preparing for your surveys, right, you want to make sure that your consulting and consulting group has experience with your accreditation partner. Also, a strategic approach, right? Here at APIC Consulting, we get calls for looking at the 30,000, 50,000 foot view of an IPC program and department. So you want to be sure that you're working with someone who has that experience of overseeing large-scale IPC programs, who can provide that type of level of experience and expertise coming in. Access to specialized talents needed. So here at APIC Consulting, we are working with some customized EMR support, right, for EPIC and Bugsy, right? So we have IP consultants on staff who are able to translate the IP to the IT. And this is a niche expertise, right? And something that we're able to do and find to help out other facilities who are in need, maybe with their EPIC implementation. Capacity and reach, right? Does this consulting group have access to multiple consultants? Maybe it's a larger project, right? And also, where are they located, right? Do you need on the ground support, or could this support be done remotely? Affiliations, right? Affiliations that this consulting group has with other organizations within the industry. That's also very important, similar to APIC and APIC Consulting and our other organization, Civic. Project management capabilities, right? How are they going to help you manage this project and getting the consultants on site as well as, working through these challenges, right? Do they have the capabilities to really manage the project from the beginning, from the inception to the end, to ensure that it is a success? Onboarding and facility assistance. This is also mainly important when you're hiring, an interim consultant, to get them on board quickly so that way they can start supporting. And the impact of working with this consulting partner. All these considerations. We also have some tools and resources located on our website for determining, what is the right fit for your consulting needs and what type of consulting do you need. So all good considerations. And with that, I think I'm handing it back over to Tania.
Okay. Well, thank you, Leslie and Catherine. So finally, we'll wrap up the presentation. But before we do that, I wanted to provide you with tips for garnering leadership support. So first, be sure to prep for leadership meetings when asking for money to fund APIC memberships, certification, outside IP support, or other paid resources. Work through the process of aligning your program goals, your mission and vision with that of your executive leadership. Connect IPC to the facility's strategic priorities and be very clear, simple and concise, and direct in your messaging. I'll stop here now and welcome questions. I'm happy to talk through any real world challenges that you're facing, as I think that might be some of the more valuable discussion we can have. So we'll move into Q&A at this point.
Okay, Tania. Question for you, Tania.
Sure.
What are some tips on how to engage frontline staff and even leaders of other departments to believe that IP is their responsibility too?
Great question. So I think often when that question is asked, it is asked as, how do I engage as a one-time function? And engagement is not a one-time function. Engagement is a relationship. And so the way that you engage leadership, the way that you engage frontline staff is by building relationships before you need something. It's easier to have an ask when you have a relationship, and it's easier to bring your ask across when you have an established relationship. So my modus operandi, if you will, is I expect all my IPs to be on their units and to be getting to know their frontline staff and to be getting to know the leaders that work on their units or their outpatient areas or wherever it is. So that when we identify gaps and we want to deploy an initiative to improve that gap, and there are asks related to that as it relates to resources or support. So not only do we have to work with the frontline team, we also have to work with leaders to provide that resource and support. We already have that relationship. And so that is the best answer I can give you about garnering engagement, is build the relationship before so that you already have the engagement in order to more easily facilitate an ask.
Great. Thank you, Tania. Okay. Another question for you, Dr. Bubb. Related to slide 10, in your experience, what are some examples of other healthcare roles or even non-healthcare that translate to a strong future infection preventionist? Meaning also, What do you look for when hiring a novice IP?
Yes, very good. So for me, I think any healthcare worker, almost any healthcare worker, not all for sure, but most healthcare worker can transition to a role in IP, especially if they have patient-facing responsibilities or they have operational responsibilities. I think that really enhances a program. I had mentioned in that slide, like microbiology or laboratory folks, public health folks, I think easily transition into infection prevention. But what I think is the most important aspect or attribute of an IP is their potential for leadership. And when I say leadership, that doesn't necessarily denote someone who is aspiring to be the SVP or systems director. It is someone who has the capabilities to build. I'm going back to this building relationships with other people, because it is through relationships that we get this work done. And so you don't necessarily have to present with those skill set upon first hire, but I have to see the potential in you for having to build those skill sets, the desire as well as the potential.
Great. Thank you, Tanya. All right. Do you have time for another one?
I think there's a few in the Q&A section here that we could probably go through a couple really quickly.
There are a few for consulting
Yes.
services. Maybe we can answer some of those too.
Certainly.
So yes, we would consult consultants for sure. How much experience do your consultants have with non-traditional infection control areas? During COVID, we did all sorts of locations that were healthcare related and non-healthcare related. And so from this perspective, yes, non-traditional infection control areas, we have a lot of experience with that as well. So just get in touch with us and we can walk you through that. Let's see, I'm wanting to know about what we should be mindful in drafting contracts for services, things like scope of work, et cetera, for a prospective consultant. That's a whole webinar in and of itself, but when you're working with a consultant, you want to I would want to make sure that if there's a backup in case something happens, family things happen, a variety of things happen, and you don't want to be in the middle of working with a consultant on a very important project, and all of a sudden, they need time away for a very good reason, but now you are nowhere. So, I mean, that's a major consideration. And that's one of the things that we have in our contracts, just saying that we're able to push through given the number of consultants that we have. But other things, you really want to be very detailed about the scope of work. You want to be detailed about confidentiality. A lot of hospitals have a BAA, that you would want to sign, which is to ensure that anything that they see or understand or they develop on behalf, if they are developing something with money that you're paying them, then you own it. There's a number of considerations. Feel free to give us a call. We can walk through that with you.
There's a question about a question already answered, which is how do you change the culture to improve EBP versus what providers have been doing for years? Many answers are that it's not been a problem before. Why should I change now? This is a real scenario for IPs, and I validate and hear what you're saying. The answer is that you may not be able to change it. And also you may be able to change it. I think that if you can present that there is a problem in a way that could be digested by those providers, that might be one way to look at this or to strategize around this. Another way is to develop a relationship with someone on that team that is more open to your concept, your thought process and your concepts, and to having dialogue in order to chip away at the resistancy. Sometimes, this resistancy, we have to chip away at it, and it takes months, maybe sometimes years, and sometimes it doesn't change, and that's just really the reality. If it's something that is an organizational priority, you might want to garner other leader support that sort of interact with these providers or oversees these providers. So that's some strategies that might be helpful.
And then someone asks, what do you mean about consulting? Does APIC actually have consultants? Yes, we're owned by APIC, and so we have consultants that will assist. Um, it's on a paid. It's not a free service. It's a paid service, but we'll match other prices that you get out there for consulting, and we're really here to help. So let us know, give us a call or send us an email and let us know what you're working on, and we can tell you if there's free services available or if we recommend the paid services, things of that nature. And then what do you suggest for rapidly expanding healthcare systems and how to incorporate existing IP staff with those being acquired? So mergers.
Or mergers. Another real and often very difficult challenge for IPC departments. I suggest team building. I think that making sure that people are knowing each other. If I'm not sure what the question is asking, but there are many challenges around mergers and acquiring new staff based on mergers, if that's the question.
Yeah, it
Uh,
seems like how to incorporate existing IPC staff. So if you're rapidly expanding the healthcare system and you're acquiring, and you have your current IPC staff, and then you are also acquiring IPC staff. So maybe like how to do that in a efficient manner.
yeah.
Any thoughts there?
So I think this can be overwhelming and probably can lead to burnout. So making sure to stagger onboarding of the staff that are coming on. I don't know if these staff are going to be new staff or existing staff somewhere else, but certainly they're going to be needing to be onboarded to your culture and your organization. And the merger has to, I guess, I keep thinking mergers here, and I may be wrong, but you have to apply a systematic approach to how you're doing things. And I think that this could easily lead to burnout among all staff. So staggering onboarding, making sure that people are paired up and having mentors, I mentioned this before, could help with that. Regular check-ins with persons that are coming into the department as well as existing staff to make sure that workload is balanced are some ways.
Right. I think that there's no other questions here in the box. Um, Catherine, you've answered a lot of those for folks. Thanks for doing that.
Absolutely.
And here on the screen, if you would like to connect with everyone on today's presentation, especially Dr. Bubb, Catherine, myself, you can do that by using the QR code. If you are not sure about how to use the QR code, basically get your phone out and you go to the camera function and a link will pop up when you focus on this QR code. And so we're very happy to connect with you. And again, if you have questions, feel free to ask them. We're here to help. And thank you so much. Thank you to Dr. Tania Bubb. It has been a pleasure as always. She is a wealth of knowledge, and she has been such a good friend to APIC over the years. We're very, very happy that she gave her time and her talents today to be with us.
Thank you. Thank you for having me.